Live, Dr. Chapman.
Well, good evening, everybody. I'm really pleased to welcome all of our participants from Washington State and beyond for our first ever Washington State Orthopedic Association Regional Educational Outreach Program, in short, REOP. This is a really compelling program. We're really pleased to have a regional host always host this and put together the program. And I think we have a really compelling program. We want to put it all together in one tight hour with brief, pertinent presentations that are hopefully thought-provoking. There are some questions that we offer your audience participation to see where you're coming from. And we really think that our speakers tonight will really provide some behind the scenes and bigger picture perspectives that I hope will really want you to become more engaged, for instance, statewide activities through organizations like WSOA and WSMA. I really want to thank our SSF team and Emily from WSOA, as well as our board, for helping put this together. And just briefly, I'm going to introduce him later again, Dr. Paul Pottinger, great nationally eminent person, great colleague at UW Medical Center, head of ID there. And he's become a public spokesperson from the ground level one for COVID-related concerns. Dr. Neal, Shonnard, long-term friend and colleague and pro-lion surgeon, successful entrepreneur also in the South Sound area with his ASCs there and his organization. And we're really appreciative of all of your inputs. Last but first, Dr. John Keefe, very dear friend of mine, and he's the host from Spokane. And one key part of this regional outlook program is to connect with our members across the state and hear from them directly what concerns them, what's going on in their part of the state. So without much further ado, welcome to all of you. Welcome to our panelists. And Dr. John Keefe, please take the microphone.
Thank you, Jens. For most of you watching this tonight, you have to look east to find Spokane. Spokane's also where the new day dawns and where the future comes from. And hopefully this will have an impact on the future of orthopedics, and hopefully we can continue to collaborate with our Western colleagues. Many of you probably have not been to Spokane, but Spokane is just in the Idaho border. There are about 520,000 people in Spokane County, but we have a very large catchment area, and the largest cities, north, south, east, and west, are listed here. So there are a lot of people that come from a long ways away to come to Spokane, not usually for the food, but mainly for the healthcare, which is the biggest industry in Spokane. As I mentioned before, we're very close to Idaho, which, as far as I know, does not have, or at least they don't think they've had a problem with COVID, although the numbers speak differently. I'm a member of Northwest Orthopedic Specialists. I've been in Spokane and had the good fortune to be in the same group since 1988. We've grown from 7 when I joined to now a total of 40 providers. And you can see the sort of breakdown here. We started an ambulatory surgery center in 2004, much to the horror of the local hospitals. We also have our own MRI, which we use quite a bit. In our group, we have virtually all specialties represented. Most of our associates are fellowship trained, some with multiple fellowships. And more recently, most of the people who are interested in working with us have done fellowships. We have 4 new physicians on partnership tracks, and you can see their names. They've been a great addition to the community, and we're happy to have them with us. I think the biggest change in our group in the last few years is we have a robust and dedicated leadership team. They have the unconventional practice of using data to help us make decisions, which is heretofore was sort of, you had a hunch and maybe we should try this, but now we actually have metrics and performance data that we use to make decisions about various things in which direction we should move. That's been a huge change in how our practice has been run. Not everybody's wild about it, but we have good reasons to do that. And I think that overall profitability and efficiency of our practice has been enhanced dramatically by actually using numbers instead of, gee, I think this might work. We also are members of the Ortho Forum, and we use their data benchmarks to help guide what we do. And we have very granular data that we collect ourselves and analyze ourselves and use that to make decisions about what we do in terms of need for new associates and what markets we might get involved with. We see about 75,000 patients a year. We do about 5,500 surgical cases in our ambulatory surgery center and about 6,000 interventional pain cases. Our inpatient cases are roughly 3,700 or so between the 4 hospitals in Spokane, and we do about 3,500 MRI scans a year. These are annualized over the last 3 years, and they've all trended upwards, especially ASC cases in the last couple of years or so. Just for example, this is, and I'm sure Neal would discuss this in greater detail. This is our trend in total joint replacement at our surgery center. You can see the numbers, and I don't have the most recent data for the last few months, but we're running out of room to do joints at our surgery center, in part because patients are escaping from the hospitals gleefully in most cases. And we've just kind of run out of room. So how we expand this is sort of difficult, and whether we start doing them on weekends or expanding the hours or how we do it, we're not clear. We do not at this point keep people overnight, although that's probably our next move, is to keep people for 23 hours in the same facility. But the ASC has been a wonderful tool for the community and certainly for us. We also are expanding some of our service lines. We've opened 3 urgent care centers. Some are working better than others, and it's a little hard to assess whether it's COVID impact or just timing or location. But we're continue to collect data and try to give patients an alternative to expensive and inefficient emergency room care. We also have a physical and occupational therapy in 2 locations, and that's been really helpful in terms of integrating how we take care of our patients. We're averaging right now 70 patients per day between the 2 clinics, and that seems to be expanding rather rapidly. We also finally started having DME available at all of our clinics, and we see about 7,000 patients a year at all of our clinics for that. We've also upgraded our MRI software so we can do more scans per day and enhanced our scheduling. So we're getting more of those done as well for much less expense than at the hospitals. Everyone's been impacted by COVID-19. Our big thrust in the beginning was to give the health of our staff, because as you know, you can be open, but if you have no staff, nothing happens. So we've been very strict and thorough with policies about COVID. We have a dedicated person at the Department of Health that we turn to if we have any questions whatsoever. And we have a task force that met basically daily in the beginning of this to try to sort this out and see what the best direction might be. We have had much more strict and refined screening procedures than any of the hospitals for our patients at the ambulatory surgery center. And now we're starting to do rapid testing for urgent and emergent cases at our surgery center, which you don't want people, hanging around with fractures for too long if you can get a rapid test done. Only in the last month or so have the hospitals been forced to cancel elective cases. And that's pushed some patients to the ambulatory surgery center that might not have chosen to do that before. But we certainly welcome their business. We are the only independent orthopedic group in Spokane, except for some very smaller 1- and 2-person groups. Providence has 2 big hospitals. Multicare has 2 fairly large hospitals, and they've also purchased all the primary care clinics and most of the urgent care centers in town. So that's an issue we have to deal with. They collectively employ about 16 orthopedists, and they continue to recruit orthopedists around us. this has been addressed with them before. They continue to do it. We have noticed that their patients, even if they've previously been our patients, are referred internally within their system. And despite all these things, we still try to maintain a spirit of co-opetition with them. We still maintain leadership positions in their orthopedic programs, and we'd like to work with them somehow, but how that's going to work is unclear at this point. So the things that we find challenging, as everyone does, the declining Medicare and other reimbursement is certainly problematic. Insurance companies get sneakier all the time with changing insurance plans and excluding providers, bundled payment plans, et cetera, most of which are beyond my ability to understand. That's why we have a great administrator people that do that. So the future is unknown, but we're doing the best we can. And I think collaborating with all and some of you and sharing ideas could certainly be helpful for all of us. So that's that.
Great perspective. Thank you, John. And thanks for taking the lead off. One question, then we'll head to Dr. Pottinger. And you gave several great segues for his presentation and his thoughts. In terms of these larger chains, and the co-opetition, that's a great word. How formal are the negotiations with that, and why would there be an interest of these large healthcare cooperatives to exclude you? Are you, quote, expensive? Do you not fit the norm? Are you not compliant with policies? What's the incentive for larger chains to kind of try to squeeze a well-established, very well-recognized group like yours out of the way?
Well, I think you'd have to ask them. I think it comes down to that they basically their profitability is better with their employed physicians than with us. We have our performance metrics and whatnot, and our infection rates, all those other things, and we compare very, very favorably to the employed physician model we have in every respect. And they love to combine our physicians' data with their physicians' data at sort of an aggregate database that makes them look better. So why they don't want to play with us, I think, has all to do with fiscal responsibilities there. So
I think we should explore it more. Full disclosure, I work obviously for one of those larger healthcare entities that John was just referring to. And again, I'm sitting in those internal data committees, and I think this should be explored in greater depth, because data validity is always a great subject. And again, I absolutely always would like to have the best practitioners in the healthcare system I work with. And I'm looking at you as an extremely experienced traumatologist and sports medicine doctor. I'd have no problems running over to Spokane to you to have my long overdue knee osteotomies done, for instance.
Come on over.
So without much further ado, and John will obviously render a lot of further input, we have Dr. Pottinger next, and we have 3 questions for the audience prepared that we can run. And you can answer or not, but briefly during this kind of a prelude, we have these 3 questions going. Please just hit the submit button. Dr. Pottinger is not just an MD, he's also a doctor of tropical medicine and hygiene from the London School of HTM. And he is a graduate of the Yale University of Medicine, University of Colorado residency, and he heads UW Medical Center's Division of Infectious Diseases. He has been a major director and a very well-respected educator. He's literally won every single house staff and educational award one can win in UW. He's a very modest person. He has also been very influential in inspiring many UW graduates to go to East Africa, something that Dr. Keeve is very keen on, also, so a shared quality there. And when COVID hit, he was one of the very first people to kind of be canvassed about what does this disease actually mean. We asked him to speak today on, for healthcare providers mainly, on the inside scoop of, now we've had immunizations, most of us had it, so it seems, and maybe we can hit the question number 2 on, is this safe for us to now kind of relax some of the very stringent rules? Number 3, also, when can we kind of expect the general normalization? And what are these mutations all about? So, so that's kind of the gestalt. We can just run through those questions. Paul, without much further ado, and again, I just couldn't help myself but talk extensively with your tremendous credo. One question I'd add to this whole potpourri is, are these ASCs safer than a general hospital in terms of hospital-acquired infections? Is there an ASC-acquired infection? So put that onto your potpourri of questions to answer. Thank you for being here. I'll shut up.
Oh, I love it. Thank you so much. This is great. It sort of stinks that it takes a pandemic to be connected to all of you guys, but I really do appreciate that invitation. Such a nice introduction. The reason I really enjoy talking with you is that I get to learn from you more than I could ever teach. So for example, all those questions I had for this whole group, Dr. Keeve answered in terms of the impact of the pandemic on their practice over there in Spokane. And I would love to hear about that from all of you guys. Time is tight, and my prediction is that if your life is anything like mine, you're probably sick of going through the valley of Zoom. So I want to keep this as interactive as I can. I do have some introductory remarks regarding some of the questions that Jens has asked, but hopefully we have time for some interactivity. And please do keep me on time, because I'm not watching the clock. So you need to, otherwise I'll go all night. I will. So you call me off when we're getting close to the end of the time, if that's okay. And thanks for these interactive questions as well. You know what I'd like to do is share screen here for a moment. This is a little unusual. Typically for a nice lecture invitation like this, I would have a full set of slides, and like that nice slideshow you just saw. I'm just too damn busy, so I apologize. But this is what I thought would be most helpful for you that I just cobbled together during those introductory remarks. Let's talk about COVID-19. The epidemiology, where are we? I think you guys understand the situation. It seems nationally that every day is worse than the day before. This isn't necessarily going to be true for much longer. If you look at the list of the top 20 deadliest days in American history, 18 have been within the last month. It's like that. And yet, I think the Galveston hurricane was a bad day. There may have been one other bad day, the Battle of Antietam or something. But otherwise, when you get to the level of 3,000 or 4,000 Americans dying of one cause per day, this is what we're talking about. And yet the curve, we hope, really can start to turn. Let's look at Washington State. This resource is one that I suspect all of you know. This is the Institute for Health Metrics Evaluation, IHME. They do this for each state, but they happen to be based here in Washington. So we really do trust the level of accuracy and the predictions and the models that they build. So what they're looking at, I just showed you deaths. There's a lot more to COVID than deaths. It's about economics. It's about the fraying of our social fabric. But if you just talk about the ultimate metric, legs up, legs down, this is it. And they are predicting that we will end up with over 6,000 dead by the beginning of May. They are very humble about this. If we as a society can do the right thing by immunizing like crazy, being careful with our personal protection, which we'll talk about, this number, we can bend it down. And if we screw up, we can certainly make it worse. But that's our local experience. And to me, I didn't show you the map because I ran out of time to build it. But for me, what's so humbling about this is the fact that this is not a Western Washington problem. When this first came out, we knew this was going to be urban, the Pacific coast. Absolutely wrong. This is a statewide disaster. And those of you who are on the eastern side, those of you in the center of the state, you're dealing with it every single bit as much as we are. In fact, in some cases, much more heavily, because the resources for human resources, the pool of labor to draw upon may be reduced. And so, thanks to all of you for providing the care that you do in spite of these incredibly difficult odds. One of the things that Jens wanted to talk about over here is these New Mutants. Apparently The New Mutants is a movie. My teenage son says it's not a great movie. I don't know if that's true. But when we talk about New Mutants, we're talking about mutations coming across the global pool of viruses over time. Let me just be very clear. Cast your mind back to medical school. Yes, mutations are expected. Remember, the coronavirus, whether it's human coronas that we've all had in the past or these animal coronas that we're now dealing with, they are made of RNA. Their blueprint is RNA, not DNA. That's key because it means that, like influenza, they're very error prone. We love being made of DNA because we can have a carbon copy every single cell, except when we catch cancer or make a sperm or an egg. Every other cell is like the others. For COVID, it's not that way. They turn over very quickly. They're very error prone, which to us in our arrogant eukaryotic ways sounds terrible. If you're a virus, you love errors. Errors are your best friend, because even if 99% of them lead to death of the virus and it fails, one time in 100, one time in 1,000, one time in a billion, you're going to have a mutation that actually confers a selective advantage. Charles Darwin knew nothing about viruses, but he knew evolution and he knew what natural selection was. So the one that you have heard the most about is what you see here. I like this graphic from the New York Times, looking at mutations in the so-called B117 or UK variant, UK mutant. I'm actually more worried about certain mutations coming from South Africa we'll talk about. But basically what we're talking about is that in a certain region of the RNA that encodes for the spike, remember the spike is what gives the surface radiation, the corona look to the virus. Those spikes at their very tip, they will bind to the ACE2 receptor in the human lung and respiratory tree. That's how they hold on to us. That's how they infect us. And in the case of this B117, these mutations lead to amino acid substitutions. This is what the spikes look like up close. This is the amino acid sequence. And these are the mutations. So they're very few mutations, but what they do is actually confer a more fit tip or binding domain on the surface of the spike. What that means is that the virus isn't smaller, it's not bigger, it's not faster, it's not more durable, it's just stickier. It holds on to the target within the human body more avidly. And what that means, of course, is that the effect to us as clinicians is that the load, the amount that would infect, the infectious dose is reduced by 50%. These are 50% more catchy, not 5,000% more, just 50% more. Doesn't sound like that much, but in an logarithmic pandemic situation, these little changes can have huge implications if we fail to protect ourselves. So the biggest questions that come with respect to these mutants, and again, what I'm showing you here is B117 UK. There are a couple of others in South Africa, not yet detected here in Washington State, although they may well be. It's possible. They are more catchy. And the question is whether they are also more or less virulent. We'll come back to that in a moment. The quick answer is we're not quite sure that that's true. The diagnosis has been an issue because the tests that we do, molecular-based tests, the dreaded, what does one of my patients call it? The devil's fire stick you stick up your nose. That's a PCR test looking for the RNA. And that RNA, if the RNA backbone changes of the virus, the negative predictive value of the test may be implicated. And indeed, beginning of this month, this message was sent out by FDA warning laboratories, not clinicians, but labs, that if they use one of a small number of proprietary lab testing platforms, they may have a harder time detecting these new mutants. The truth is, this is not felt to be the case for most of the testing that's done in America. This is a small number of vendors that have this issue. And frankly, every lab in the country is now scrambling to make sure that their primers set, the accuracy and reliability of their tests remains up to date. Here in Western Washington and across the entire state, you can at the moment depend and rely on the tests that you get. So in spite of letters you see like this, we still think that standard PCR testing is good. And the same is true for antigen testing. If you're actually doing antigen testing, you happen to work for a university that's doing frequent antigen testing of football athletes and such, those tests should also be as accurate as they were before. The mutation has not yet eroded their issues. Again, I think the bigger issue that comes up, we'll come to this in a moment, is about masking. What have you heard about masking and prevention? Is it time to double mask, to upgrade your mask? We've had the mantra this whole time, right? Cover your face, give yourself 6 feet of personal space. Don't go out if you're sick. And if you do see other people, do it outdoors. That's what we tell the general public. What we're telling healthcare providers like all of you is get your damn shot. So the immunization piece as soon as possible. So appreciate that question we had a few moments ago. It looks like most respondents here tonight have been fully immunized. Great news. I'm one of those. If you have not yet, it's good news. You should soon have access to that immunization. Everyone who's a patient-facing clinician is under Governor Inslee's guidance, which is in keeping with CDC. You are authorized to get it. And there should be an opportunity in the very near future for you to be immunized. If you have questions about safety, effectiveness of the immunization, I'm happy to take those either in a group or we could do it as a private chat too. There may be medical issues that you have questions about. I'm happy to do so. What's so stunning to us on the immunization side is how incredibly effective and benign these shots are. It's very strange. For me, I don't know about you, I got my first shot. I happen to be Pfizer recipient. And then when I got my second shot, unlike the first time when I had a little bit of a sore shoulder, I actually had a cytokine flow. I was too sick to come into work. At UW, like where you work, you can't work if you feel sick. I felt sick. I had fever, felt feverish, chilled, muscle aches, where my ribs meet my sternum, that hurt, everything. Next day I was fine. That's a small price to pay for what we know is a substantial improvement in the protectivity against COVID, wild type, old school COVID. And yes, we are confident and optimistic about these UK variants and also potentially the variants coming from South Africa. When you get a vaccine, there is a polyclonal explosion of B cells that will attack different portions of that molecule of interest, the antigen. It's not just one clone, it's many clones, meaning that there is some healthy, beneficial lack of focus, more broad protection than you would get if it was just one clone. So that's good. And we do think that based on serologic studies, that most recipients who have a good immune response to their shot, they should be very well protected against the so-called UK variant. It's here in Washington state. We have detected it on a small number of cases here in Western Washington, and no doubt that will come to be true in Eastern Washington. I've been working today, haven't checked the news. It's probably already been described. If not, you should assume that the UK variant is in your community. That's key because you can practice with confidence if you yourself are immunized, but you need to continue to do the basic protectivity that we would always do. Not necessarily because we think the UK variant is more likely to break through the vaccine, but because for any viral type, including wild type virus, you're not 100% covered. You're probably more than 95% covered. Someone's going to be in that small fraction that might not be covered due to random chance, due to immunosenescence. As we get older, we get less of an immune response. So we should all assume that we are at risk of having exposure to this infection and continue to practice masked, but I think with greater confidence, a little bit more spring in our step, and a sense that we are probably protected. Thus, the slide that I show you here regarding double masking, the issue, as we talked about, is that you have a smaller infectious dose of these new mutants. It takes less virus to infect you, so unless you are quite meticulous and perfect with your technique, there's a greater threat and greater likelihood that people who especially have not been immunized, they can now catch this infection. Cloth masks work. That's what I wear. This is what I wear to my car. I've got one of these little cloth masks here. Happy to do it. And it's opaque. When I hold it up to the light, I cannot see through it, not just because it's black, but because I've got enough layers of weave. So even if I were not immunized, actually, I would be good in a single layer of mask. Having said so, for people who are less choosy, less willing to spend money on a good mask, yeah, sticking a second mask on is completely fine. And if your patients, family members, friends, and well-wishers ask you about that, should they wear one mask or two, if people are asking the question, they've got a certain sphincter tone on them, feed that sphincter tone, put them in a second mask, it's fine. The trick is whatever they wear, they cannot fiddle with it, they cannot fuss with it, and if it fogs their lenses, then it's the wrong answer because that's not sustainable. That will cause hand to face, including conjunctiva. That's a risk. So you'll hear a lot more about double masking. I think you're going to see a lot more of it in the community. I think it's fine. It does not get us out of where we are in terms of providing exponentially more protection for the general public, and it doesn't get us out of our issue getting each other and ourselves and our families immunized as soon as we can. So the basics of prevention stay the same. Yeah, question, please.
Interrupt you quickly. Great questions from the audience. Superb insights. I could listen to you all evening on, but we'll have to obviously move on. Dr. Galina asks, how long does immunity from the immunizations last? So we'll shoot there. And number two, Dr. Hagen asks, can you carry or transmit the virus if you're vaccinated? For instance,
Yeah, great question. So neither one has an answer. We don't know, but I can tell you what I think. We don't know how long the immunization durability lasts because we only got these things approved a month ago. We are literally too early. I'm optimistic based on these screaming high titers that we will probably have lifelong or at least more than a year of immunity. Could we go into a seasonal influenza situation where you got to get your annual COVID shot? Yeah, it's possible. No one yet knows. Number two, can you then shed the virus even if you've received the vaccine? Not clear, probably not. And if you do, it's probably very little. That's based on one subset of one of the vaccines called Moderna, in which they did not find that recipients were able to shed the virus. The reason I'm hedging on this is that it's a huge issue for us in our healthcare setting here. It's a very hot topic in infection prevention, employee health. We will get the answer to your good question, I hope, in the next month. That's Pfizer and Moderna really want to answer that question, because when the answer is no, then people will feel even more excited about getting their shot. Meantime, even if you are a vaccine recipient, healthy specimen, good immune system, you still need to mask up because we have to assume that you might be a threat in terms of shedding to others. The only other thing I wanted to say, because I do get this question sometimes, is on treatment. And if you are to get sick, how would we treat you? If you want to learn more about this, we have a nice website, which is here, put together by my colleagues here at UW, called COVID-19 Treatment. It's a series of free slide decks on this topic. The quick answer is there is no treatment ever studied proven to save lives, ever. Hydroxychloroquine, ivermectin, monoclonal antibodies, nothing's ever been shown to keep people alive. There are some treatments that seem to be associated with a lower risk of severe disease or hospitalization. And in particular, that's a combination or cocktail of antibodies made by a company called Regeneron. And when these are combined together, given to nursing home patients who've been exposed to the infection or who have early infection, they may be less likely to have to go to the hospital. So we're excited about that. It's still very early days with respect to those data. And one of those studies, actually called Blaze, was just released a couple of hours ago. I haven't looked over that yet. So we're hopeful that that might work. These are antibodies. They're infusions that take hours. They have to be done in a hospital using an IV. We won't get out of our pandemic by using these antibodies, is what I'm trying to say. Only the vaccine and good personal responsibility can do that.
Our board member, Alan Greenwald, asked, just on a big picture perspective, and then Galina had another question, Dr. Galina. He asked, this herd immunity concept was such a giant thing. Is 60% that critical epidemiologic threshold, and when we can kind of bend the curve? That's been an overused thing. And please fill out the final COVID question that we are just posting right now for all the audience members.
Yeah, I love that question too. I'm eager to see what folks think of that. So regarding herd immunity, great question. I'll stop my share. We don't need that anymore. Which we also call community immunity. The herd refers to rinderpest, which is the measles of cows in Africa. But yes, herd immunity, that's what everybody calls it. So modeling from IHME, from NIH, CDC, and WHO, they all end up at roughly that same number, that we will not bend the curve until we reach at least 70%, at least 2/3 of the vulnerable population should be immunized. What's so intriguing to me is that, of course, that number depends on the efficacy of the vaccine. Vaccine's 50% effective, you're gonna have to get higher than that. This vaccine is highly, highly protective, and therefore we might be able to get away with a smaller number. I don't think that that gets people off the hook with respect to personal responsibility in getting their vaccine. But I would say, because we have such a small supply of this incredibly precious resource, it does give me hope that we may be able to bend that curve sooner than we would have thought. I can tell you here in my hospital, we have a very big hospital, tens of thousands of people in our whole system. All of our healthcare workers have been offered the vaccine. Almost everyone has taken it. We have zero. I'm knocking on, there's not a real piece of wood in this whole damn room here.
I'd offer you my head.
Thank you, sir. I'll do the same. We have not yet had a failure. We've not yet had one healthcare worker break through, either with a community exposure or healthcare exposure if they have received the vaccine. Remember, your maximum protection begins about 5 weeks after your second injection. So we're just now getting into that phase. But even before we reach maximum titers, very, very protective. And I love seeing these results.
Can you see the screen, Paul, with the poll results? I think I should not book an expensive cruise until after middle of 2022.
I think what you are likely to see, my friend, is that if you want to be a high roller cruising and such, you probably need to have proof of immunity. I think we're going to split into two societies in this transition period, where people can either wear their badge of honor, I've got my vaccine, then casinos, music venues, cruises. That probably could be a realistic thing. In fact, I think I just saw on the news a couple of days ago, there is one cruise line that's doing this for early adopters. It's an incentive. Having said so, when do we get back to normal? It all depends on these next few months. Can the new administration deliver on the promises they've made and exceed them? I think they've promised 100 million doses in 100 days. They need to do more than that. Remember, when we talk about doses, it takes 2 doses to get immune. So they really need to do more. And if we can actually revolutionize things, don't ask a hospital to immunize folks. Have it happen at the post office, at Starbucks. When the Amazon guy comes to your door, he gives you a shot. We need that kind of radical thinking to quickly get past this. And I'm really hopeful that we can do. Exactly when the time will be there, I don't know. I don't know.
In the New York Times today, there was this incredibly encouraging article from Israel that showed, as you know, very, very positive results with a better than predicted immunity to at least the Pfizer product, which I received also. So 2 more questions, then we'll probably have to move on. Again, this is so fascinating. Thank you so much for jumping out of your meeting to our meeting and educating us. So quickly, Dr. Galina had a question I thought was cool. If a patient had COVID, when can you start get immunized formally?
Yeah, nobody really knows. The guidance says that you can be immunized anytime. You may choose, I think the word CDC uses is may choose, to delay by up to 90 days. The concept is that once you've had COVID, you are unlikely to catch a second case within 90 days. We have seen this. Actually, it does happen. My personal guidance to those people is give yourself a month off and let us catch up with everybody else who's still vulnerable. And then at the end of 30 days, get your shot. I have not come across someone who has a legit second infection within a month, and very rare within 3 months, but within 1 month, I just have not come across that. That allows us to take that one precious dose and get in the arm of somebody different. So that's what we say, but you can get it done anytime. There is not a rule.
We probably have to reschedule another meeting with you because the questions just keep flying in, but this is obviously so near and dear to all of our lives and livelihoods and the lives that we're asked to protect. So very quick fire, just quick question. So PCR tests, too sensitive, almost yes or no answer. Are they just too sensitive? Is the bar too high? The dilution protocol is too far-fetched?
Yeah, don't test again. No test to cure. They're hypersensitive. They pick up cases within about 48 hours after infection. First 48 hours, you can't trust them as much as you can. But once they're positive, that person may stay test positive for weeks or months. Don't test again. Just go by time. You can take that person, they're coming in, they want to get a hip or a knee. They happen to have a pre-procedural screen. Fine. Reschedule them for 20 days later. Even 10 days, to be perfectly honest, if they weren't going to get intubated, your colleagues in anesthesiology will thank you. If you make it 20 days, the chance of that person then spreading COVID out of their trachea during the case is 0. That's what we do here.
Final question from mine, then we have to come to a close. Sorry for all the questions that are coming in. You're just a great speaker and such a fund of knowledge. A politically charged question, so a light one to end with. How can we trust those COVID death numbers? Again, there are all sorts of paranoias. I come originally from Germany, and now there's a huge debate as to what games are you really playing? What's really a COVID death? The standards are very different. So maybe a word of wisdom on trusting numbers and how can we trust numbers? Where are the boundaries?
Yeah, great question. It's a great question. Early in the pandemic, it was clear that we were probably having real issues with case definition. Remember all those nursing home people who died, case fatality rates of 50%. Our case fatality rate is now down to less than 1% because we're able to test so aggressively. So it's a great question. My thought is that our testing in the US today is so sensitive that we are really able to pick up the great majority of these cases. And yet, if you look at the total number of human beings who have died in our country in calendar year 2020, and compare that with calendar year 2019, there are a difference of approximately, I think, 150,000 unexplained deaths, excess mortality. These are people who did not have a COVID test, but they died for any number of reasons. And you know how the coroner reports go. So the answer is, I think we can trust the numbers. They clearly are undercounting. We clearly have a greater burden of COVID-19 than we know because some people just don't get tested. And the numbers don't lie. Those actuarials are real. There are a lot more people dying out there than we have even tracked. We assumed they're COVID-19. The numbers you get officially from state departments, except for Florida, which is just a weird place apparently, but except for Florida, the other states will give good numbers and they're apparently, I think very reliable. I know we're out of time. It's totally up to you. I'm happy to go mute and then reply. There's a little chat function. I'm happy to chat back to folks. These look like great questions over here. If that's suitable to you.
I have one more question. For.
Oh, sorry, we lost your audio again. Sorry about that.
Neal is going to talk about ASCs. Is it safer for a patient? COVID and those other microbes we're forgetting about, those little things called staph and strep and whatever. Is it safer from an epidemiologic perspective to go into a small a controlled environment like an ASC rather than a big hospital where there's some godforsaken bugs floating around? Just big picture.
Yeah, not COVID, but you're thinking about bacteria. Oh yeah, I think it's all about the level of excellence and quality that's brought. There are so many excellent so-called day centers, surgical centers. As long as there's someone, in my experience, who is responsible for the quality control, looking at the data and implementing best practices, that can be fine. The State Department of Health, I think, is, I was going to say biased against. I think they've been burned with some day centers. I'm not thinking of ortho, but just day surgery centers, because often that level of quality and staffing is not there. There's no reason that that should be true. We struggle with our staffing here at this hospital, and as you know, we're a big ass hospital. There's no reason why a smaller center should be any less safe. Indeed, theoretically, should be more safe if they're willing to invest in what it takes to do that, which is, I'm sorry to say, human beings who do nothing but that. It's a dedicated discipline. I think that quality control, infection prevention is the price of doing business in orthopedics. It's not something that can be done on the sly, on the side. If so, you'll get burned. That's my thought.
Absolutely outstanding. Please accept our collective thanks. If you are able to take some of those questions online in the chat function, fantastic. Great segue to our final speaker. So Neal Shonnard is very well known. He's a pro-line surgeon at PL Washington. He's a proud father of 3, and he has been the co-founder of the first statewide registry for spine surgery scope, and he has been truly talking about quality, very much quality oriented. He has a unique scope of being hospital based and ASC based, and he's a successful head of a large group in the South Sound area. So we asked him to talk about ASCs, which are very heavily under pressure under COVID. And without much further ado, Neal, thank you for joining us.
Oh, thank you, Jens. Wonderful to listen to the speakers so far. And I will touch base a little bit on the practical nature of what we are doing with COVID with regard to our ASCs. But just first to get a feeling of the audience, I'd like to ask a question about how many of you use ambulatory surgery centers, either have one yourself or use them once a week or twice a month. If you could reply so that we can see the audience's familiarity with ASC. So it's a 2/3, 1/3. Very good. So let me proceed with what it is that I'm going to give a little history of ASCs. They started in Phoenix, Arizona with Wally Reed and John Ford, who were essentially trying to find a way to control their time. They found it arduous and burdensome to have to try to schedule in a large facility or hospital. And they couldn't control their time. They'd get bumped for emergency, or they just couldn't get the cases on and get home at a reasonable hour. So the first surgery center in the US was a Surgery Center. That was the name of it in Phoenix. It started in 1970. In the 70s and 80s, the national societies bought in anesthesia and orthopedics primarily, but the national societies bought in. And growth in the industry was spurned by Medicare's DRG prospective payment system. That one ASC resulted in 5,700 ASCs, certified ASCs, and there's a difference as of a couple of months ago. A certified ASC addresses those quality issues that were raised earlier, where you look at infection rates, you look at blood glucose levels, normothermia, antibiotics on time, MIPS measures that are commonly applied in inpatient settings. And what the ASCs, the certified ASCs, give you is data. And they also give you data that's comparable to inpatient data. And they also transparently report economics, the cost of care. And I'm going to show you how impactful that is, because the feds are watching and they do see this information. Lastly, between 2000 and 2024, there's been a sea change in 3 of the major stakeholders in healthcare. There are 6 major stakeholders in healthcare. I call them the 6 Ps, but patients, physicians, payers, product and device manufacturers, purchasers, pharma. Those are the 6 Ps. COVID has made a sea change in patients. Patients originally advocated for ambulatory surgery centers for their care. Now they're demanding it. They do not want to go to the hospital. And they're very insistent about that. There are two questions I get from my patients when they tell them they have to go to surgery. And one of them is, "Doc, you're going to take care of me in your ASC, aren't you?" And the other is, "I don't ever want to go back to the hospital again." And then what Medicare has done is they have sunsetted the inpatient CPT list. That means if Jens wants to do a 7-level scoliosis surgery in an ASC using a robot and BMP and percutaneous screws, he can do it. Now, there's no chance in hell he ever would, but he could do it. And there will be others who will be doing that. And that, especially 3-level, they'll attack the apex of a curve and do an L1 to L3. But let me show you what will happen with this change. This all evolved because two major entities, payer entity, CMS, and a association, the Ambulatory Surgery Center Association, got together to share this data coming out of certified centers. And what the feds found out was they saved a heck of a lot of money if these cases were done in an ASC, and that the cost of doing it in an inpatient or the cost of doing it in a hospital outpatient department was still twice the cost of doing it in an ASC. And they found, in looking at this economic data, that there's reason for quality purposes and for cost purposes. And now you're seeing these high volume, high reimbursement procedures shifting to the ASC. And you'll see that in total in 2024. So this 5,700 Medicare certified ASCs provide data, and you get data from California, you get data from Texas, you get data from Florida. The state of Washington is what is called a CON state. That's a certificate of need. That's an extra layer of regulatory burden through the Department of Health of Washington that you have to satisfy. And it takes 2 years to get your CON, and it costs you 65 grand. And if you don't get it the first time, you get to pay the fee over again. But you get data from those entities, and you get safety, quality, efficacy, and cost data. That's very important. Now, the vast majority of ambulatory surgery centers that Paul was speaking of that don't really participate in data, they are actually 2 to 3 times as many as the certified ASCs. And they occur everywhere, and they're often office suites, and you get no data from them. So when you look at what has happened when you have comparable data from inpatient and comparable data from certified ASCs, where they have comparable data, so whether they have safety, quality, efficacy data, you can do comparison. When you look at healthcare utilization, you can do comparison, and that's where the feds have learned the most. Now, there are some entities such as surgical site infection, which only has an inpatient CPT, so you got to be mindful of where you can compare and where you can't. But the important thing is to look at that HCU piece, because I've listed 3 of the registries which are informative in healthcare utilization. Jens mentioned Spine Scope. We demonstrated in the papers published in that registry that we saved the state about $75 million each year in participation in the registry. In the vertebral compression fracture registry, we've actually been able to demonstrate to Medicare and have testified before the MACs, which are called Medicare Administrative Contractors. There are 5 of them in the different jurisdictions. Testified before them showing that the ASC can reduce your cost 5-fold over inpatient care. And at a minimum, it reduces your cost 2-fold, but realistically 3 to 5-fold. That's impressive. And that will alter the reimbursement regimens that will come out of CMS. And if we have time, we'll touch base on that. If not, that's the point of the data. You can compare. Because the sea change that's occurring here is motivated by the 6 Ps that I mentioned, and 3 of them are mentioned on these slides. The patient, the purchaser, those are your Microsofts, Amazons, Boeings, PACCAR, Costco, and the payers, the Blues and Aetnas. The 3 of them are using ASC quality data to turn and say to the health systems, this fivefold increase in cost and no measurable improvement in quality or outcome, none. ASCs outperform in every category for every piece that is studied in quality and cost. So they're demanding, these three stakeholders are demanding access to the ASCs, and that's what's driving the inpatient CPT list going away in 2024. So here's your paradigm shift. Anesthesia has improved the safety of anesthesia. Pharma has delivered a 72-hour local anesthetic that can be used in TAP blocks for OBGYN or anterior OLIF spine fusions, or you can use it around pedicle screws. You can use it around tibial plateaus. Ambulatory surgery for trauma. 100% of your upper extremity trauma can be done in an ASC, or what you would call a cold trauma. Schatzker 2, tibial plateaus can be done in an ASC. Tibial nailings can be done in an ASC. This whole paradigm shift revolving around pharmacology and anesthesia, and surgeons are participating by developing minimally invasive surgeries. Now, there's some experts, particularly those on the call today, who are maximally invasive surgeons, and this doesn't apply to them, but for those of us that do minimally invasive surgery, that applies. Probably the most important thing to recognize on this slide is dark blue, and I call it fiduciary integrity. No more shell game. The hospital systems use the shell game of hiding the costs so that they can take paying patients and subsidize the non-paying patients. And that does not occur in the ASC. There's fiduciary integrity and there's fiduciary transparency. And as such, as we do more and more, our ability to increase our storage, increase our sterile processing, the size of our autoclaves are massive. And so essentially what we're becoming is boutique hospitals catering to the three stakeholders who are asking for us to respond. And we are responding. Now, it's a perfect storm. If you use ambulatory surgery as part of your practice, it's a perfect nightmare if you're a health system. So Jeff Bezos, Warren Buffett, Jimmy Dimon came out and gave an article in the Wall Street Journal in January 31st of 2018. And what they weren't aware of is 5 weeks later, a publication co-authored by two of the folks speaking today was going to be published in JAMA that showed what they asked for in the Wall Street Journal. What they asked for is they needed data because they've got 1.2 million people who are employees, and they need data on when is that person going to come back and help us build the airplane? When is that person going to come back and help us deliver the products that we do? JP Morgan Chase is involved in almost half the businesses in the US. They need to have predictive analytics. And in March 7th of 2018 in JAMA, an article was published, and Jens was one of the co-authors, on predictive analytics for spine fusion. And that came from data from the SpineScope registry. And predictive analytics are what evolved from registry. And so what you're seeing is the purchasers, Amazon, Microsoft, Boeing, JP Morgan Chase, the patients, and the payers, because the purchasers are telling them they have to do this. They wouldn't do it on their own, but now the payers are saying that we want to incentivize patients to go to the ASC. So you're going to see your copays disappear. For ProLiance employees, and we're a 250 doc plus organization with thousands of employees, your copay goes away if you have your surgery in an ASC. And the same will occur with Amazon, the same will occur with Boeing. And that's why you're seeing all of these procedures migrate to the ASC. And because of that, there's going to be a very large sucking sound that health systems are going to hear, that where all these procedures are being pulled off. Medicare's inpatient code means that everything that you want to do in an ASC, you will be given the choice to do so if you as a clinician think that you can do that case there. So this motivates physicians to participate in ASC, but you must control and own your data. And your data has to be about cost, quality, safety, efficacy. And health systems will react and struggle to react. One of the questions that I was asked to remark on is consolidation. So here you see Tenet and US Physician International, or Envision and AmSurg, or Optum and SurgCare affiliates combining for massive amounts of money. We just got finished talking with a bunch of private equity folks and said thanks, but no thanks. The concern is, will a small but agile physician-owned group of ASCs be able to compete in this environment? And my answer to that is hell yes, and easily. We have the data and we have the data tools. In COVID, we went down to 20%. We're back up to 86%. We're compliant with CDC and DOH. We have the PPE. We are preoperative testing, and we're responding to the patient's demands to get to our ASC and stay out of the hospital. With reporting, we've already built the surveys that CMS is going to ask for the next 5 years on their comparative survey site. And we believe that ASCs that are small, physician-owned, agile, and integrated into the revenue cycle and the scheduling are going to be much more efficient than the behemoths. And we know how to risk contract because we collect data for risk adjustment, so we can respond appropriately and stay out of bankruptcy, because you have to do that. And you have to remember, all ACOs and all clinically integrated networks need ASCs. And those ASCs have to be successful. So when I look forward to the future, I see there's only 4 reasons you're going to go to the hospital. It's an emergency and the ASC is closed because we keep bankers hours. You're too sick and you cannot come to an ASC. Your comorbidities are too great. Or you're too obese, similar comorbidities too great. Or you have a high risk, high reward sort of surgery, which really should be done in an inpatient setting. Thank you, and glad to ask or answer any questions.
So, outstanding lecture, Dr. Keefe. So 2 great speakers following your survey. So there seems to be hope, if I gather Neal's information, for the small, high quality groups to have a niche and compete with the large hospital chains. And again, from Dr. Pottinger, I did feel that a high quality, a well-run outfit like yours can very well survive in this. So do you want to close us out tonight with your thoughts on these 2 lectures and how this affects you and your local orthopedic group and community?
Well, I'd like to applaud Neal and Paul. They had great presentations and germane to everybody's practice. I think if you're not involved in an ASC, I don't know why you wouldn't be. It's been the only thing that's actually gotten it's sort of kept our group together and gotten the hospital's attention because we're doing more and more and more cases, spine cases, joints, et cetera. And I think it's sort of the rising tide raises all boats. Actually, most of the innovations in outpatient anesthetic techniques and everything else, we sort of pioneered at our center. Adductor canal blocks, we're now using an alternative to Exparel that's 1/10 the cost, that works with equal efficacy. So lots of things. We have the agility and ability to experiment in an ASC has been great. And we take those techniques and take them back to the hospital. So I think the ASCs definitely have a bright future, and we're glad to see all these procedures come off the inpatient only list.
If I might make a closing comment, for those clinicians who are on the Zoom call, if you are a young clinician, be mindful that the original motivation for ambulatory surgery remains. All of us dearly want to control our time, and the presence of an ASC in the practice future of the next 2 decades is guaranteed. And it's only a matter of whether you have access to it or are joined to a group that has one, or you don't have access to it and you're in a health system where you're not going to have. So be mindful when you're looking at your employment opportunities. That's a very important ancillary that you want to check. And just like was mentioned earlier, that the physicians in Spokane also have other ancillaries besides the ASC. Those are important aspects of your practice, and they augment your practice, and they really make your life much more joyful.
I think the other thing that's important to note is that the reason, as you alluded to, the reason that we